A very good evening, all of you. Welcome to our day 6 dinner session. So, this will be our penultimate dinner session in this 7-day challenge. So, I hope you guys are all ready. So, today we'll go ahead with a case based discussion. In fact, day before yesterday, we had a homework question, the WAND, and most of you have found out what this is all about. And also, I've discussed the same in brief about its implications or about its relevance in managing hot tooth, right? So I hope you checked out yesterday's dinner session. So in today's dinner session, as I mentioned prior, we'll go ahead with a case-based question, and we'll leave out one question unanswered for you so that you can find out through active referrals. Okay, so let's go ahead. A very good evening once again. So today it's day 6 of our 7-day challenge. So as you know, we have taken up this a mini challenge after our successful 21-day challenge. So let's go ahead. So morning we had a wonderful meditation session for 20 minutes, and then we discussed about an update from the government, which was posted yesterday on update on COVID relief aid, right, from various countries, and also the equipment we're trying to procure in the process in the form of COVID relief aid. So let's hope we'll have more assistance from all the parties which are involved, and let's really hope that this pandemic ends very soon. So today's case-based question or scenario-based question, we have the following context. So 34-year-old patient with pulmonary tuberculosis, diagnosed with pulmonary tuberculosis, is on anti-tubercular therapy and presents with joint stiffness, severe pain and difficulty in movement related to joints. Laboratory analysis or investigation revealed uric acid levels to be around 10 milligrams per deciliter. So which of the following drugs can lead to this elevated or I don't know, you must say whether it's normal or elevated. So which of the following drugs can lead to this levels of uric acid? Rifampicin, pyrazinamide, streptomycin, none of the above. So before we go ahead with the discussion, I want you to check out the following keywords. So I've tried to highlight some. So as you can see, the age of the patient, he or she is on anti-tubercular therapy and presents with the following clinical features, right? Very young age, but still these findings seem to be very much present in this particular case because of the lab analysis. I mean, a lab analysis is a picture which is justifying his or her clinical symptoms, which could be because of one of the following drugs or none of the above. I mean, you must be answering it, and you're the best judge to answer this. So, what do you think is a more appropriate answer? So, straightforward, the question is all about the adverse effects of anti-tubercular drugs. So, these are the keywords which help you in answering this question. As you can see, which anti-tubercular drug? So, we've tried to highlight that. Also, you have these clinical features, and also you have a hint in the form of lab findings. So, usually, uric acid levels are in the range of, I'm sure you know the answer, 1 to 4 milligrams per deciliter, but there can be elevated levels, especially in cases of gout. So these are manifestations of gout, if you remember. So 1 to 4 milligrams per deciliter, even though this is normal range, the maximum upper limit, according to PubMed indexed articles, according to various standard references, it's still 7.8 milligrams per deciliter. But in this case, the uric acid levels are 10 milligrams per deciliter. So we're talking about hyperuricemia. Which anti-tubercular drug leads to hyperuricemia? So that's the question we have. And we're trying to beat around the bush by giving you these clinical features, the age of the patient, the medication he or she is on, and the lab findings. So as I said, case-based questions are, in fact, relatively easy to answer if you know how to pick them up. So, okay, it's good to see that some of you have already started answering this question. So before we go ahead with the answer, let's shift to our virtual whiteboard, present some notes or important points in the process of this discussion, and then we'll get back to this case-based scenario once again. Right? Also, you can see a representation, a schematic representation of gout, where there is deposition of uric acid crystals, precipitation of uric acid crystals, right? So we'll get back to all of this in a short while. Okay, first and foremost, since we mentioned about anti-tubercular drugs, so we'll just list out various primary and secondary or first line or second line drugs which are given in case of tubercular or anti-tubercular therapy. So in the meantime, you can try answering what these drugs are, what the names are based on your ability to recall your memory. The first and foremost, let me just list out these drugs. Anti-tubercular drugs. So as you know, we have first line drugs. First line because they act against these bacilli very effectively. So anti-tubercular efficacy is very good, and also the toxicity is relatively low, okay, compared to second line. And also we have various second line drugs. So we'll just name a few for sake of completion of this. So as I said, first line of drugs, high anti-tubercular efficacy as well as low toxicity. So we have isoniazid, represented by INH or H, and then we have rifampin or rifampicin, pyrazinamide, which is represented by the letter Z, and we have ethambutol, and we have streptomycin. So I'm just following your methodology of mentioning things in shortcuts. I mean, I learned from the younger generation, present generation. Usually, I had this habit of typing everything at length, in detail, without shortcuts. But now I think I should resort to, and I should, change my methods as well when I'm dealing with a different generation altogether. Okay, so first line drugs, you can say isoniazid, rifampin, pyrazinamide, ethambutol, and streptomycin. And we have several second line drugs. We'll mention one or two. So ethionamide is one which I wanted to highlight. Yeah, ethionamide, we can mention it as ETM, okay? Small t and small m. And then thiacetozone, TZN. Paraminosalicic acid, PAS. And then cycloserine, CYS, etc. Okay? And also we have kanamycin, amikacin, capreomycin, ciprofloxacin, ofloxacin. We have this entire list available in any pharmacology textbook. My reference is Tripathi. Okay? So if you remember, I previously mentioned that every day, if you can master one classification, it adds to your confidence tremendously. Just one classification per day. Within 15 or 20 days, you'll be mastering all major classifications, and within 30 to 45 days, you'll be mastering almost all the drugs which are available in your standard textbook, right? You can give it a try, because I personally followed it during my preparation, even during my UG, and the level of confidence it gives you, you cannot simply express in words. Right? So anti-tubercular drugs, we have first line and second line drugs. Second line drugs, we're calling them as second line because they have low efficacy or high toxicity and are used only in specific conditions, right? Okay, so this is about anti-tubercular drugs. Now, let's move on to, most of you have answered it as pyrazinamide. So I really appreciate you for answering it and hitting the bullseye right away. So why pyrazinamide? So what's the mechanism involved with it? So pyrazinamide, as you rightly mentioned, it inhibits uric acid secretion in kidneys. So that's something which we'll try to highlight. Yeah, let me just. Oh, it has gone to rifampin. In that case, let me just do it again. Yeah, pyrazinamide. Why pyrazinamide? In fact, gout, it can be because of abnormal metabolism of purine, right? And also, there are secondary reasons why there can be gout or hyperuricemia. In case of cancer chemotherapies, where there is enhanced purine metabolism. Also, in case of certain drugs like pyrazinamide, which inhibit secretion of uric acid. So we'll just make a note of it. So hyperuricemia. is due to inhibition of uric acid, UA, as per a convenience, secretion in kidney. Okay, so this is considered to be one of the adverse effects. And another major adverse effect associated with pyrazinamide is hepatotoxicity. So in case of liver disease, pyrazinamide has to be avoided. Right? Contraindicated. Hepatotoxicity, right? And hyperuricemia. So we'll just mention this in brackets, right? Okay, the mechanism of action of this adverse effect or whatever, based on a convenience. Okay. Now, yeah, I'll just stop it here. Yes. And what about pyrazinamide? So as you know, pyrazinamide, ethionamide, which we have come across in second line, and also isoniazid, all of this fall under the same chemical group. That is, they fall under nicotinic acid derivatives, right? Nicotinic acid derivatives include isoniazid, pyrazinamide, and ethionamide. Isoniazid, pyrazinamide, H, Z, and ETN. All of them fall under the same chemical group, that is nicotinic acid derivatives. So the mechanism of action of these drugs is also same. So pyrazinamide or isoniazid, the mechanism of action is they inhibit mycolic acid synthesis, right? So mycolic acids are important structural components of mycobacteria, as you know. So let's leave about mechanism of action, but I have a question to you in the process. Pyrazinamide, in specific, is known to be effective or highly lethal against intracellularly located bacilli, as well as at those sites where there is inflammatory response. So what could be the reason for this selective toxicity of pyrazinamide? So let me repeat the question. Why pyrazinamide is highly lethal to intracellularly located bacilli, as well as at those sites where there are signs of inflammation? So what's the reason behind this selective toxicity? So try finding out. It's an interesting phenomenon. And now let's move on. So rest of the things I think we covered, right? Hyperuricemia and hepatotoxicity are the ones which I wanted to highlight in this context. And then we'll move on to gout. So why gout? Because in this particular case scenario or context scenario, we come across some clinical features which clearly indicate the fact that there has been deposition of these crystals, urate crystals, uric acid crystals in joints, leading to those pains, difficulty in movement, etc. So what exactly is gout? We'll try to highlight certain points regarding the same. So gout, as you know, it's a metabolic disorder characterized by hyperuricemia. So in fact, the normal levels are very, very important. So you can mention them as 1 to 4 milligrams per deciliter. And you say elevated, or 7.8 milligrams per deciliter is considered to be the maximum upper limit or normal upper limit. So 7.8 milligrams per deciliter is normal. I'm sorry, 6.8. Above 7 is considered to be a gout. I think previously I mentioned it as 6.8, right? Yeah, normal upper limit. So above 7, there will be saturation and precipitation. The symptoms of gout are manifested, right? So consider this very, very important. And also hyperuricemia. So this we're talking about uric acid levels, normal plasma urate. Also, I wanted to highlight another important point, that is uric acid has poor water solubility, especially at low pH. So as the acid levels are rising in blood, especially in cases of hyperuricemia, the ability of this uric acid to dissolve further decreases, and it leads to saturation, crystallization, and this excess is deposited in joints, soft tissues. You know about TOFI, right? We discussed about the same previously as well, TOPHY. So there are contexts or scenarios where we can even find secondary hyperuricemia, right? So where are the situations where you find secondary hyperuricemia? As I mentioned, in case of cancers like leukemias, lymphomas, etc., where you're going ahead with chemotherapy or radiation therapy, which will enhance nucleic acid metabolism and overproduction of uric acid. So that could be one scenario. Also, right, there can be drug-induced hyperuricemia. The best example which we are discussing now, pyrazinamide represented by Z, also ethambutol, which is another first-line anti-tubercular drug, can also lead to hyperuricemia. According to Tripathi and also various standard reference articles, PubMed indexed articles, the link of which I'll be sharing in the description part after we conclude this session. And other drugs like thiazides, furosemide, pyrazinamide, ethambutol, levodopa, they reduce uric acid secretion from kidney, thereby leading to elevated uric acid levels in the blood, right? So I'll just mention another drug, levodopa, okay, etc. So these are the secondary causes of hyperuricemia, apart from the primary metabolic defects that can happen with purine metabolism, as you're all aware of. So in this context, try to highlight the normal plasma urate levels, and also when do you start seeing the clinical features or manifestations of gout. The levels are very, very important. That is above 7 milligrams per deciliter. And so these are some of the things which I wanted to highlight. And there are some interesting points which I'll highlight in this process. So let me just enter them here. Interestingly, this uric acid crystals precipitation in joints is enhanced in acidic environment for the reason which we discussed prior, because the solubility of uric acid decreases further in acidic environment and also in cold environment, right? So in acidic and cold environments, the precipitation increases, because of which usually the peripheral organs, including fingers, great toe, are involved in case of gout. So consider this very, very important. And there is a male predominance, interestingly. So male to female predilection, it's 4:1. And also, uric acid levels can be elevated 10 to 15 times to that of normal before clinical manifestations of gout are seen. Mostly, we see that we come across these cases in old age. I mean, arthritis, gout, these are the cases which we come across in old age people. Also, there can be exceptions, as in case of our context-based question. So usually, why only in old age people? It's not that they are healthy till then and something happened right then. It's because of a body's resilience. So as interestingly mentioned, uric acid levels can be elevated 10 to 15 times to that of normal before clinical manifestations of gout are evident. So this is another clinically relevant point which I wanted to highlight, okay? So, we just extend it. We'll just place it here, okay? And we'll extend this so that we'll know that these two are linked. Right, so these are some of the things which I wanted to highlight in the process of this discussion. So we tried to cover anti-tubercular drugs, the list of drugs, and also pyrazinamide, its mechanism of action, and also I've asked you one question in the process, right? I'll post that question here so that you can find out and let me know tomorrow in our final dinner session, okay? So before I summarize all that we have discussed so far, let me just post the question here. Homework question in regard to pyrazinamide. So pyrazinamide, Z, is highly lethal to intracellularly located bacilli, as well as to those at sites showing an inflammation or inflammatory response. White. Okay. So it will be appropriate if I change the color of this. Let's make it pink. I think most of you like pink. Assuming that male to female predilection of attending our sessions is 1:10, which is not an exaggeration. Right. So before we conclude, we'll draw a happy face. It's like a practice for me as well for future sessions. Yeah, we'll also place some ornaments to the ear, nice hair. The happy guy, right? So these are the things which I wanted to highlight. Hope you made note of the same along with me and also try to get back through mail with this homework question. So anti-tubercular drugs. So first line and second line, we've seen the list, and also we've seen the adverse effects of pyrazinamide in specific, although other drugs also have very serious adverse effects. So hyperuricemia, hepatotoxicity, right? Yeah. And also we discussed in the process about gout. So gout, normal plasma urate. Also there can be, apart from the derailed metabolism, there can be secondary reasons for hyperuricemia. So these include leukemias, lymphomas, and the subsequent treatments leading to enhanced uric acid production. Also some drugs preventing the excretion of the same in kidneys. And also we have seen some interesting facts like acidic and cold environments where there is enhanced or increased precipitation of these uric acid crystals in joints. And also male to female predilection, 4:1. And an interesting clinical finding based on observation is that the levels can rise, right? So 10 to 15 times, it's not 10 to 15 years, I'm sorry. So let me just mention it here. Yeah. 10 to 15 years. Also, in fact, in one of the cases which I've come across, their levels have been elevated to almost 10 to 15 times. Anyways, you can use both the numbers in both the contexts. So the levels can rise to such an extent that even for 10 to 15 years, the patient can potentially remain asymptomatic before the manifestations are presented, okay? So these are some of the topics which I wanted to highlight. And before we conclude, let's revisit the case-based question and check out what the answer could be. Yes, so a 34-year-old patient with pulmonary tuberculosis is on ATT and presents with joint stiffness, severe pain, difficulty in movement, clinical features of gout, which is obviously enhanced by or prompted by one of these anti-tubercular drugs. Laboratory analysis reveals uric acid levels to be 10 milligrams per deciliter. So you should know the normal levels only to make out this difference that these levels represent hyperuricemia. So which of the following drugs can lead to the same? So if there is ethambutol in the options, you can even include that because as per the literature, we have pyrazinamide, ethambutol are also associated with secondary hyperuricemia. Okay. In the normal levels, urate levels in plasma, 1 to 4 milligrams per deciliter, up to 7.8 is considered to be a normal upper limit, and up to 6.8. I'm sorry, I don't know why I'm obsessed with 7.8. Somehow there seems to be some miswiring in my brain. So 6.8 up to 6.8 milligrams per deciliter, it's considered to be normal upper limit. Okay, let me just recheck it. Yeah, 6.8 milligrams per deciliter. In fact, I got this from one of the PubMed indexed articles. I'll share the link, and if there is any update required, I'll post it in the description part of the video. So it's pyrazinamide, as most of you have rightly mentioned, the beginning of the session itself. Good. I really appreciate your enthusiasm. Take care. Good night.